Good afternoon, everybody, and welcome to Intuitus's webinar on the healthcare sector, and specifically on the subject of the current dynamics in the healthcare services sector and the question of a fundamental pivot and digital transformation or a short-term trend. That is the key question we're going to be discussing this afternoon. So thank you for attending. Let me start by introducing our panel, if I can, today. The two most important people on the panel are, let me introduce Robin Wright. Robin is an Intuitus consultant, but also a career veteran in healthcare, having had various CIO roles in various health and social care settings, including in the NHS. And our second panel member is Paul Marchmont. Paul is a technical director, CTO if you like, with experience across various sectors, but including last 10 years spent with one of the leading software providers in the pathology sector. So thank you, Robin and Paul, for joining. Briefly myself, Adrian Astley-Jones, I'm the CCO at Intuitus, and I will be acting as our chair today. Our agenda is concise and short. We want to discuss and stimulate a debate around what is driving change in the healthcare market currently, and specifically looking at that in terms of access, quality, and cost. So those are the key areas we want to discuss. In terms of logistics, we'll probably be typically we spend 30, 35 minutes on the webinar. There is a question facility in the GoToWebinar control panel, which allows anyone to ask questions. You can type them in, and as they come in, we'll answer them if we can. And please don't feel that you need to wait to the end. Ask questions whenever you may wish to do so in the webinar. So what I would like to move on to really, I guess, is really sort of framing up the question, what is driving change in the healthcare market? And before we dive into access, quality, and cost, really, I guess start maybe with yourself, Robin, in terms of the bigger picture of change, you know, so at the top level, what is driving change? Is it consumerism? Is it demographic pressure? You know, what are your thoughts on COVID? Can you perhaps give us a picture of how you see that at the top level, and then we'll sort of drill down after that into access, quality, and cost?
Yes, I think certainly in a social healthcare system. Sorry, I'm getting a terrible echo. Is everybody hearing me okay?
Yes.
Right, okay, I'm getting echo, but I'll carry on. In a social healthcare system, which such as the UK NHS, access, quality and cost and the balance of these is always what's necessary, both from a political and from an organisational perspective. The need to ensure equity of access, the need to ensure that people get seen in a timely fashion according to their clinical need, the need to ensure that the quality of care that they receive is to a standard, and need to ensure all of that is affordable is what drives social healthcare systems in the UK and across the world. Most recently, we've obviously had the COVID challenge, and I think what COVID has done is just accentuated all of those dimensions. You know, from an access perspective, clearly COVID has overwhelmed the system, some might say, although the steps that have been taken by governments to shield us from the disease, I suppose, has enabled that to be managed better. But I think it's fair to say that the system has been overwhelmed by COVID. The quality dimension is obviously being impacted by that access challenge. So if you are a patient who has got a threatening condition that might be cancer, for example, and you're not being seen in a timely manner, then your eventual outcome might be compromised by the situation that we face. Clearly, those people are now all getting into a queue. So from a cost perspective, the cost of future care to that cohort is not going away. and the COVID challenge, whether it's in testing, whether it's in the high propensity towards intensive care, or whether it's in terms of the social cost, is clear for all to see. So I think all of that wraps up into an enormous challenge for healthcare systems across the world, and clearly requires some disruption to enable us to manage our way through that. So I think the threat is from COVID, although the wider threats are there from demographics, from technology and drug cost inflation, and from consumerism. You know, I think millennials now work and use the health service, and their expectation of what they get from the health service is far different to their parents and grandparents. So yeah, the NHS faces that big consumer challenge for the first time in its history, I think.
Okay, thank you, Robin. That's interesting. Paul, perhaps I could ask you a similar question just at the top level before we get through into the sort of the slightly more detail around access, quality, and cost. Is from a technology point of view, you know, what are the things you're seeing in terms of technology either enabling or conversely inhibiting change in the healthcare market? You know, so for example, you know, are old systems a real inhibitor to change? You know, will we be able to overcome those legacy systems quickly enough to meet some of the challenges we're facing? What's your view on that technology area, just at the top level?
So I think, I mean, for me, one of the big drivers and the big subjects that the big technologies that could well be an enabler and is starting to show that it's an enabler is the artificial intelligence and the area of artificial intelligence and machine learning. There is, you know, there's almost not a week goes by where it comes up as a subject matter for discussion within the NHS, and funding going into this area is significant now. The NHS has set up an AI lab organisation, and NHSX, which is the digital transformation arm, is targeted with digital transformation across the NHS. You know, it is a strong AI is a strong focus for that organisation, and machine learning, and it is, you know, it is going to solve a lot of the issues that we or potentially could solve a lot of the issues that we're going to talk around access, quality, and cost. You know, that technology has has the potential to make a massive difference and solve those areas. So, you know, AI, machine learning, and the use of big data analytics are key areas, because the NHS has, you know, a wealth of data, masses of data that is unused really, and needs to be used. It feels like it owns that data, but it does not use that data as well as it should do. So AI and big data analytics has the potential to solve that problem. In terms of the inhibitors, I mean, the architecture within the NHS systems is often a legacy architecture, legacy technology, multiple systems, complex systems, not talking to each other, or talking to each other to a lesser degree. Interoperability, as that is called, between systems is a another big drive for the NHS Digital, because they know that is, you know, a big problem for the NHS and a big inhibitor to moving forward with technology.
Okay, thank you.
Yeah.
Well, let's move on, if we can, gents, to access. So taking on board all of those comments that you framed up just there for us, What are the thoughts on access? And what I mean by access, I guess, is smarter, quicker, and alternative access to prevention, support, diagnostics, treatment, so on and so forth. What are the challenges in this area around lifestyle improvement, online services versus millennials, consumerism, so on and so forth? Robin, perhaps you could start perhaps just framing up your thoughts on that access challenge.
Well, I think the challenge clearly is to move from a physical to a technology-supported virtual environment. But I think the model whereby GPs refer patients to hospitals and they go and gather there in their masses and wait a couple of hours to be seen by whoever they're there to see is probably something that's not going to return, certainly in the short to medium term. So there's a real push in the system now to move towards that virtual model, whether it's in prevention by educating people better how to look after their own health, whether it's in support through the application of telemedical devices in people's homes that enables them to be assisted in some way, whether it's a change in the way that we diagnose disease to a more near the patient model rather than having to go to a central facility or a central specialist facility. And then when you get into treatment and rehabilitation, I think the treatment aspect of care is going to have to, I think, be shortened. So there's going to be a push towards a very much shortened hospital stay, which is something that I think healthcare systems across the world have been trying to do for certainly the last 20 years. It's well known that there are risks associated with long stays in hospitals. So, there's a quality and access element to this, that if we have people in hospital for a shorter period of time, get them discharged back to their home, then costs are reduced, quality is improved, and clearly access is better for the patient. So I think, the only way we're going to achieve that, I think, is by the appropriate use of technology and the safe use of technology to enable the kind of pre-treatment, pre-operative stage and the rehabilitative stage to be better supported by people in communities, whether that's professionals in communities or people who are self-supporting.
Okay, and if we then sort of take that background forward around there's really a technology challenge here, and Paul's already alluded to the fact of we've got disparate legacy systems, but new technology is always coming into the market. I guess the question is how quickly or otherwise can these changes be made, and also do we think funding is in place via the NHS or procuring such services from the private sector? Is that going to, what are the challenges in that space?
I mean, I probably leave Paul to maybe say something about the technical challenges, but I mean, I think the technology is already available that better supports remote care. I think the difficulty with that technology is that it needs to be applied to a new model of care, a new care pathway. And almost since 1948, when the NHS was established, care pathways have not been disrupted in any meaningful way. So there's a kind of institutionalised bias towards the way things are currently done. And it's the disruption of that from a kind of people, process, methodology perspective, I think, that's going to present the greatest challenge. Also, the problem always in healthcare is, that you can't introduce everything at once. So there's a kind of dual running aspect to it, and in an organisation that employs 1 million people, for different systems to apply in different parts of the service is always a very difficult thing to achieve, because geographical boundaries get crossed and people might expect to get the same service in London that they get in the home counties, etc., but they may be receiving some of their care in London and some of it in Essex. So there's big kind of human issues to be resolved in terms of how you introduce change, what's the sequence of change, and how quickly can it be adopted.
Yeah. Okay. So from both a technology point of view within the NHS and private sector suppliers going into it, there are a number of barriers, I guess, or impediments to the pace of change, which one, I think what you're saying, Robin, is culturally there is a real pivot required if the adoption of technology is going to be taken up in the pace that perhaps is needed. Is that reasonable?
And it's not just kind of people's low propensity for change that's the issue. I think there are, if you look at the average clinician's workload, it's very variable. If you take the average clinician in the average hospital, and if you look at a surgeon as an example, a surgeon is doing outpatient clinics, he's educating his junior staff, he's doing admin and management, he's in the operating theatre and he's seeing patients post-operatively and so on. He's having case conferences about patients alongside all of that. So disrupting that sequence of activity, that kind of spread of activity, and resequencing it in some way so that it can accommodate different models is an enormously complex task in my experience, and one that needs to be managed very carefully. So I think if we're going to get serious about this disruption to that aspect of how we deliver care, then we're going to have to put quite a lot of money into it and educate the public in a way that hitherto we've probably excluded them from. We need the public to understand what change is going to look like for them and for them to be part of that change process.
Yeah, and I think just to kind of add, I think that the NHS needs to move more into the area of prevention from a technology point of view. There are some great devices that are out there and are coming to market, very innovative new devices and software technology alongside that, with AI, artificial intelligence and machine learning technology built in there that will actually could prevent serious situations and maintain health for patients. But that's not made it into the NHS yet, and into the mainstream. And those sort of things need to be need to make into the NHS. And the likes of the mass data that's going to generate needs to be passed into an technical architecture that is fit for purpose and is usable alongside the data analytics that I talked about, the big data analytics. Otherwise, it's not going to be effective.
Yeah. Well, I guess that might lead us on to sort of the area of quality, which we're kind of touching on already. Is we've got a potential for rapid change and large scale change if that can be affected through culture and combining technology. But clearly there's an issue in there, or a challenge in there, especially in a healthcare setting, around quality. How do we maintain and improve quality as the workload increases? So rethinking processes, using the data in the best way. You've already touched on, Paul, AI and data analytics as a huge part to play. But what are the main challenges around quality? How do we maintain that quality, or even not just maintain it, drive it up via the use of technology? And therefore, you've got a very clear benefit for deploying that technology.
So, well, I'll answer that first of all, Adrian. I think Paul's touched on it. The NHS is an enormously data-rich organisation, but is probably, relative to other organisations of its size, very intelligence poor. So there needs to be a translation of that data into intelligence that can be used both to inform quality, but equally importantly, to inform management. The decisions that are taken in the NHS, in my experience, are very often good faith judgments, but normally taken in a crisis. It's a very crisis managed environment. I think you can understand why in many ways, because a lot of what they manage is crisis. But turning that data into intelligence, I think, is a huge opportunity for suppliers of such services to the NHS, and could represent, I think, the biggest gain to public health services if that could be cracked.
Okay.
And I do think that COVID has forced the NHS to start thinking about how things could be improved, how processes could be improved, what technology could be implemented quickly. It has moved things along probably far more rapidly than it would normally have implemented systems. Would you agree, Robin?
Yeah, I think it has presented a fantastic opportunity. I'm not sure that opportunity has been taken terribly well. If you look at, for example, the track and trace app that was piloted in the Isle of Wight, I think it's been quickly forgotten for obvious reasons. But I think those kind of experiments, because I think that was a highly experimental endeavour, lead to public confidence issues. So I think what the NHS needs in its response to COVID is a higher level of success than hitherto it's been able to demonstrate. Whether it's in the field app in the Isle of Wight or the track and trace system that is fragmented across its use. So it's like there's a real opportunity here, but I think the opportunity could be quickly lost if it's not confronted or taken up by highly competent solutions.
Yeah, I think for me, that's a prime example where actually having expert advice and an expert technology provider was absolutely crucial for them, and
yes,
they didn't take that opportunity. It is a great opportunity with new technology that has to be implemented quickly to actually go to the experts to actually develop or buy off the shelf products that will do the job.
Yeah. Conversely, there's been a very high level of satisfaction, I understand, in the introduction of remote consultations for GPs, where I think there's been huge levels of satisfaction in all surveys that have been undertaken in that regard. So that's been highly successful, and I think the public like that and have enjoyed that development. But there needs to be more of that. There needs to be a range of initiatives that enable the NHS to demonstrate to people that it can successfully introduce these changes in a safe and intuitive way. It needs to be intuitive for people to adopt it, and it needs to be safe for people to trust it.
Yeah.
Okay, let's move on to the subject of cost if we can, because this is often budgets, expenditure in NHS, and the overall healthcare supply chain is often very much cost driven. It's definitely in the press and the media and through government channels. It's all about the budgets available in the NHS for both internal NHS work and paying for solutions from the private sector. So I'd like to get your views on what are the core or key cost dynamics? What's driving that? Are we, in your opinion, getting enough funding into the NHS? And perhaps, Paul, being more on the supplier side to an extent, what does that mean for suppliers, private companies supplying into the NHS? So maybe I think I'll go Robin first. Perhaps give us your view on cost, and let me just, before you do that, I mean, we hear that 800 million has been prioritised in the NHS for NHS digital. Is that a significant number in terms of the challenges we're facing? Where will that be spent? What's your view on that whole area of cost?
So cost is an undoubted issue. There's almost no limit to the amount you could spend on this, and the public wouldn't be concerned because it's something that's sacred, certainly in the UK healthcare system. The biggest pressure in cost in the NHS and other healthcare systems is the demographic pressure. Ageing populations requiring ever-increasing levels of healthcare. 80% of the healthcare you receive in your life will be received after the age of 65, so it's not difficult to see where where the costs are arriving from. Add that to the fact that drugs and technologies are developing apace, and the drug and technology price inflation is outstripping our ability to pay for it. So those are obviously two areas. There are a couple of other areas I would highlight. One is drugs. We spend an enormous amount of money in drugs. I don't have figures to hand, but it's a very significant sum of money, and yet it's estimated that only about 28% of drugs have any efficacy at all in people that they're administered to. So there's an awful lot of work to be done to eliminate that 70% waste. They're not administered because people knowingly want to fill people with drugs that don't work. But going back to my previous comments about the lack of data and intelligence, quite often drugs are administered to people, to eliminate, the fact that they've had the drug and it hasn't helped, or it has helped. So that's an issue. Fragmentation of the system is quite a big issue, I think. Fragmentation of sectors, between primary, secondary, and tertiary and social care. They operate very largely as autonomous organisations. We talk a lot about the NHS in the UK, but when you break it down, the NHS in the UK is no more than a brand. The services are delivered by a plethora of organisations on behalf of the NHS, and that's increasing. The involvement of the private sector, whatever your view on that is increasing, and therefore the fragmentation arguably is getting greater, and isn't properly underpinned by a functional information technology environment that enables transmission of information between those sectors. And then the other area is admin and management. There's still an awful lot of paper flowing around the system, which is introducing a huge amount of cost and risk, because paper isn't the best medium for ensuring that information that informs the types of decisions that clinicians are taking. It's not the best medium for that. So I would sum those up as the main areas of cost. Getting back to the 800 million, I think that's a number that I would urge caution on. The 800 million is quoted in a tender that has been put out by NHS Digital for digital services. There's no indication whether that's new money, whether that's potential spend, or whether it's a kind of extrapolation of existing spend over the next 5 years. So I wouldn't pay too much notice to that number. Rather, I would look at all of the things we've talked about today as pressures and subsequent opportunities as the basis in which to think about entering this market. That quantum is not something I would trust too much.
Okay, that's interesting, which might actually lead us into, Paul, what's your view on, from a supplier in the private sector point of view, having run such a business, a software business in the pathology area, clearly suppliers will be looking at, what budgets are available, what should they be tendering for, so on and so forth. How do you see that playing out, and what are the constraints, especially for, our audience today, who will either be investors in healthcare businesses or looking at healthcare assets? What dynamic do you see in that area?
Yeah, the NHS, as Robin said, is a very complex organisation, and really it is multiple organisations that build up to a central organisation. What I found, and what we found is that there are various pots of money for doing specific things that you discover that you can tap into, and to meet specific software needs and opportunity needs that you might have. For example, there is the 800 million. That's for various services or organisations, but another one is the there's 140 million that they're wanting to award. The NHS has a pots of awards, innovation awards, So there's a 140 million fund for artificial intelligence and machine learning products that software companies, technology companies can tap into and come up with ideas or put their products forward for. So there are different rounds of those awards that occur, and it is possible to get some funding for either product development or for existing products from those pots. That individual trusts themselves seem to be able to use their own funding as well for if they have specific application needs. So I think over the next few years that there will be more funding going into the NHS on the technology front. It has been a problem over the last few years, but I think with what's happened with COVID, the investment in technology is now going to increase. That's my view. They may go back to their existing the existing funding, but I don't see them going back now. I don't see the NHS going back. I see it just going forward and wanting to ensure that its technology platform is better than it currently is now, and that's going to require money.
Yeah. And I think that's interesting, Robin. I wanted to ask you this question then on cost, really. Where do you think these investment decisions will be made? So, and what I mean by that is, do you see that as being national, regional, or local? And I couch that question in the context of online services across modernized care pathways. How does that investment decision and joining up new pathways, how do they sit together, and how does that play out?
So I think over the last 5 years there's been a tendency for national bodies such as NHS Digital to set the broad direction and set standards against which investment should be made. So technical standards, data standards, etc., are now being established and accepted nationally. I think the actual investment decisions, so the product choice, if you like, will sometimes be done on an aggregated basis where that makes sense. So, for example, a good example of that is networks. So where you're investing in an NHS network that requires interoperability between organisations that are attached to that network, then it's likely that those big investments will continue to be made on a national basis. Whereas if you look at the types of things that enable the transaction of healthcare activity within local areas, so the interface between GPs and hospitals and between hospitals and social care, etc., those decisions, I think, will continue to be made at either a regional or a local level against those standards. So to get the money from a national pot, you'll have to meet a range of standards, but the decision on product will continue to be made locally. And I think that's right. If you look back at the disaster that was the national programme for IT about a decade ago, and the money that was thrown at that inappropriately, then that tried to do things from a national level without any kind of sense of what it meant for local users. So I think the learning from that has helped to make the right decisions in the right place. So the standards, broad framework, etc., being made at national level, but the individual decisions being made at regional and local level. And the differentiator between regional and local would be, for example, if there's a IT system required for a radiology department within a hospital, then it would be made very locally within that radiology department in the hospital, or with other hospitals with whom they have a relationship. Whereas the ability to share clinical records across health and social care would be made at a regional level, involving all of those who participate in the local health economy.
Yeah, understood. Okay, let me let me perhaps, start to wrap this up, and we've covered a lot of ground, but there's one question I'd like to ask you both, which is, look, it's opinion, I think, which is, we all like opinions, and feel free to express what you think. Is, COVID has clearly been a shock to the system. We've spent, if we are to believe media reports, 12 billion on track and trace. That's a huge amount of money. The question I wanted to ask you is, do you think that we will have a radically different view of how we fund the NHS post-COVID, and what we need to do to, have an improved level of capacity, improved services, improved quality? Or do you think, and this is clearly just opinion, other things will come on the political agenda, and we will go back to what it was before in terms of NHS funding and NHS challenges? Big question, I know, but Robin, I don't know if you have a view on that.
Yeah, I think there'll be a short term, maybe a short to medium term thrust towards change. I think there'll be money put into that. I think it will mainly be put into the areas of infrastructure, because it's easier to do that from a national funding perspective. I think the ability for local healthcare organisations to invest will depend on how transformational they are able or prepared to be. So if you look at any health delivery organisation, it spends about 80% of its income on staff. So it's not difficult to see where the business case for investment comes from. It comes from the ability to translate staff into machines or staff into services. And that's a pretty difficult thing to do in an environment where politicians are continually challenged, and you'll have heard them being challenged on how many nurses we have in the system, and how many doctors we have, and how many healthcare assistants, and how many care homes there are, etc. So I think there needs to be, and I don't know where it comes from, but there needs to be a concerted effort to move from measuring inputs, how many staff, how many tests, how many patients, to managing outcomes, measuring outcomes. And I think that is the challenge in terms of long-term sustainable investment in technologies of all sorts, whether they're information technologies or drug technologies or biologics, genetics or whatever. There needs to be a translation of the cost base from one which is 80% biased towards people to one that enables space to be found in budgets to invest in these things.
Yeah, that makes sense to me. And Paul, same question to you. I don't know if you have a view on or opinion on that question.
Well, I think COVID has accelerated the use of technology within the NHS. It's been forced to push certain technologies forward in a rapid time frame. I mean, I think that that the NHS now realises, and that senior people within the NHS realise that they've got to up their game on the technology front. As I mentioned, NHSX, which is tasked with digital transformation across the NHS, that and notably reports directly to Matt Hancock, the Minister. So I think he will want to achieve a lot of digital transformation over the next 3-4 years, and turn the NHS into a much different animal to it is today technically, and do that as rapidly as possible. If they can make the changes that they've made during COVID, then in that time frame, then they can move a lot faster than they have done over the past few years. So I do see, I do see this being a key time of change technically, and it's the only way the NHS is going to it's going to allow the NHS to improve quality, or to, you know, to survive and handle the amount of patients and health issues that it has, because, you know, resource is not going to be the answer. Additional resource is not going to be the answer.
Yeah. Good. Okay. Well, look, I think we've actually probably come to a natural conclusion there. That's been a very interesting and clearly a topical debate with what's going on in the healthcare world and the world in general at the moment. So I would like to firstly thank all of our attendees. Thank you very much for sharing 30 to 40 minutes of your time with us today. We much appreciate that. And I would like to also thank Robin and Paul for being on our panel today. So thank you everybody for attending, and I wish you a good rest of the day and a rest of the week. Thank you.
Thank you.
Thank you.